Welcome everyone. In this video we shall be talking about immunodeficiency disorders and discuss all the questions related to it. So moving on to the first question. Which of the following statements regarding primary immunodeficiencies is true? Primary immunodeficiency. They are always evident at birth. That's a false statement. They may be present at birth. They might not be present at birth. They may even present in late childhood and adulthood. Like CVID, the common variable immunodeficiency, and selective IgA deficiency. They are the ones they present in adulthood. They are the ones that present in adulthood. Okay. They commonly present with autoimmune features. That's a true statement. This is due to the immune dysregulation. This is due to the immune dysregulation that is seen in immunodeficiency. They are mostly due to secondary causes. That's a false statement. We are talking about primary immunodeficiency, and over here the option itself mentions about a secondary cause, right? So that's an incorrect statement. Neutropenia is the hallmark of humoral defect. That's a false statement. In humoral defect, we don't get neutropenia. We might get lymphopenia. But remember the fact that lymphopenia is also not a hallmark of humoral defect, right? The hallmark of humoral defect is recurrent infections. Right? We might get normal lymphocyte count. We might get a normal lymphocyte count and get immunodeficiency features, right? So the hallmark of humoral defect is recurrent infections. Okay. So the answer would be B. Moving on to the next question. A 10-month-old male has recurrent otitis media, pneumonia, and giardia lamblia diarrhea. No tonsils are visible, and serum electrophoresis shows absence of immunoglobulin peak. What is the diagnosis? Now, absence of immunoglobulin. Whenever we get absence of immunoglobulin and no tonsils or no lymph nodes, the first thing, or rather the only thing that should come to our mind is X-linked gamma globulinemia. Right? Whenever we get no tonsils, even no lymph node, even absent lymph nodes points towards a diagnosis of X-linked gamma globulinemia or Bruton's gamma globulinemia. Okay. Now, certain important things that we need to know about Bruton's gamma globulinemia, that there is BTK gene mutation. That is Bruton's tyrosine kinase gene mutation. Now, this results in a defective B cell maturation. Which results in decreased production of immunoglobulin, right? And all classes of immunoglobulin are involved, right? All immunoglobulins are low, but your T cell function is normal, and the features and it presents usually after the age of 6 months. Okay, that's why in this question, right, a 10-month-old is suffering from it, right? And moreover, it usually affects males more than females, right? Because it is X-linked recessive disorder. Okay. Over here, our answer would be A. Common variable immunodeficiency and selective IgA deficiency. These two are the ones which present mostly in adulthood, mostly in late childhood or even in adulthood. Right. And transient hypogammaglobulinemia might present in this age group, but we got normal tonsils, right? The most important feature over here is this no tonsils, right? No tonsils or no lymph nodes is suggestive of Bruton's gamma globulinemia. Okay, the first thing that should come to your mind is X-linked gamma globulinemia. Okay. Moving on to the next question. Bruton's gamma globulinemia shows hypoplastic or absent germinal centers. Yes, that's a true statement as already discussed, right? Absent lymph nodes also suggest a Bruton's gamma globulinemia. Arrest at pre-B cell stage, that's a true statement because the B cell maturation, as already discussed, that due to BTK gene mutation, the B cell maturation is defective. So there would be arrest at pre-B cell stage. Okay. Normal T cell function discussed. There is normal T cell function and increased susceptibility to enteroviruses. That's also a true statement, and again a very characteristic feature, that enterovirus infections, right? If in a case of immunodeficiency, if there is increased risk of enterovirus infection, the first thing that should come to your mind is again Bruton's gamma globulinemia. It is also a very characteristic feature of Bruton's gamma globulinemia. So the answer would be A, B, C, and D. D should be our answer. Okay. Moving on to the next question. A 25-year-old woman has a recurrent sinus infection, bronchiectasis, and low IgG and IgA. Flow cytometry shows normal B cell count and decreased plasma cell. What is the diagnosis? Right, the first thing over here is the age. Right, it's an adult patient. It's an adult patient, and we get recurrent sinus infection bronchiectasis, that is recurrent infection, right? So we get an immunodeficiency pattern in an adult, with normal B cell count and plasma cell, right? It is without doubt CVID, because what happens in CVID, there is BAF gene mutation. And this BAF gene is responsible for conversion of it inhibits the conversion. BAF gene is responsible for conversion of the mature B cells into plasma cells. Now, due to BAF gene mutation, there would be defective conversion of the mature B cells. So there would be a defective conversion of the mature B cells to plasma cells. That's why over here you get normal B cell count but decreased plasma cell count, right? Then if we look into the other options, X-linked gamma globulinemia, this is seen in a child over the age of 6 months. Selective IgA deficiency, over here we would get isolated IgA deficiency, right? But in this question we get both IgG and IgR deficient. Okay. And transient hypogammaglobulinemia, over here, right, the presentation would be in a child and which resolves by 2 to 3 years of age, right? Again, not an answer. Our answer would be B, CVID. Okay. Moving on to the next question. Match the following with the infection. Pyogenic and enteroviral. Whenever we get enteroviral infection, the first thing that should come to our mind is Bruton's gammaglobulinemia. Okay. Autoimmunity, right? The most common immunodeficiency syndrome which is associated with autoimmunity is again CVID. Okay. Mucosal immunity, right? And giardiasis is again due to mucosal involvement, right? Mucosal type of infection is usually seen in IgA deficiency. In all the conditions where IgA is deficient, we would get mucosal involvement, right? We get IgA deficiency in both selective IgA deficiency syndrome rather, and hyper IgM syndrome, right? But if we look into the fourth option, opportunistic infection, specifically opportunistic sinopulmonary infection, my bad, and enteric infection. Opportunistic sinopulmonary and enteric infection, right? These are quite characteristic of hyper IgM syndrome, right? So our answer over here of the mucosal of option 3 would be C. Right, because opportunistic infections are usually not seen in selective IgA deficiency syndrome. Certain important things regarding selective IgA deficiency syndrome. Remember the fact that it is the most common primary immunodeficiency syndrome that is seen. And another important fact that it is associated with an increased risk of anaphylactic reactions during blood transfusion. Okay. During blood transfusion, right, a deficient IgA is a risk factor for increased incidence of anaphylaxis, right? And is the most common primary immunodeficiency. So our answer would be A1, B2, C3, D4. A1, B2, C3, D4. Answer would be A. Okay. Moving on to the next question. Which of the following statements about hyper IgM syndrome is incorrect? Now remember that hyper IgM syndrome is due to defective CD40 or defective CD40 ligand. CD40 ligand is more common than CD40 involvement. Okay. Now the CD40 and CD40 ligand interaction is responsible for class switching. For class switching of immunoglobulin. Remember that when immunoglobulins are produced, the first immunoglobulin that is produced is IgM. And then there is class switching and there is conversion into the other immunoglobulins. So whenever there is a defect over here, now the class switching will be absent. So there will be increased production of IgM and decreased production of the other immunoglobulins. Okay. So let's have a look into the options. Associated with CD40 ligand defect, yes. Decreased production of IgG, IgA and E, yes. Associated with autoimmune anemia, that's a true statement. Remember that due to excess production of IgM, it is associated with autoimmune. It is associated with autoimmune thrombocytopenia. It is associated with autoimmune hemolytic anemia. It is also associated with autoimmune neutropenia. Okay. An autosomal recessive disorder? No, this is not an autosomal recessive disorder. This is an X-linked recessive disorder. Hyper IgM syndrome is an X-linked recessive disorder. So the answer would be Our answer would be D. Okay. Moving on to the next question. A child presents with hypocalcemic seizures, recurrent fungal infection, and absent thymic shadow on CXR. The face of the child is shown in the image below. Which of the following statement regarding the diagnosis is incorrect? So we have the features of hypocalcemia, right? We have recurrent fungal infection, that is immunodeficient picture is also present with an absent thymic shadow. And we get this abnormal facies where we get a small jaw, where we get a small jaw, where we get a fish-like mouth, we get a prominent nose, with a bulbous tip, and we also get low set ears, and we also get low set malformed ears, right? So everything over here, hypocalcemia, immunodeficiency, absent thymic shadow, and this abnormal feces suggests a diagnosis of DiGeorge or DiGeorge syndrome. Right, now DiGeorge or DiGeorge syndrome, what do we get? There is defective development of the third and the fourth pharyngeal arch, which would result in defective development of the thymus and parathyroid glands. Due to the involvement of your parathyroid gland, we get hypocalcemia. Which might trigger seizures, right? So, which of the following is incorrect? Associated with a defect in TBX2 gene in chromosome 22q11, this chromosome number is correct, but this gene is incorrect. It is due to involvement of the TBX1 gene, right? So, this is incorrect. Associated with defective development of thymus and thyroid gland, no, that's a false statement because it involves your parathyroid. Gland. Associated with cardiac anomaly, that's a true statement. The most common cardiac anomaly that is associated is our TOF, tetralogy of Fallot. And if we talk about the association, we all know the mnemonic of catch 22, right? C for cleft lip and palate, we get cleft lip and palate. A for abnormal facies. T for thymus involvement and T cell defect. C for cardiac anomaly as discussed. The most common cardiac anomaly is tetralogy of Fallot. H for hypocalcemia, and 22 represents a locus, that is 22q11.2 deletion. Okay. And the final option, defect in B cell development, that's a false statement. There is defect in T cell development. Okay. So which of the following are incorrect, right? So A, B and D. Yes, B should be our answer. Okay. Moving on to the next question. A 3-month-old presents with severe recurrent infection, oral thrush, chronic diarrhea, and the lymphocyte subset shows decreased T, decreased V, and decreased NK cell. What is the most likely genetic defect? Now, whenever we have a immunodeficiency picture, we have an immunodeficient picture over here, and oral thrush, most commonly due to candida. Remember, and there is decrease in T cell, B cell, NK cell, that is a combined involvement, combined immunodeficiency, right? In a setting of combined immunodeficiency, we are getting candidal oral thrush. The first thing, or rather the only thing that should come to our mind is SCID, severe combined immunodeficiency. Now, certain important things, that which is the most likely genetic defect, all these four, all of them can cause SCID. Now, how to differentiate between them? This is differentiated on the basis of the lineage that is involved, right? Remember this as a fact that interleukin 2 involvement would result in decrease in T cell, normal B cell, and decreased NK cells. ADA deficiency would result in decrease in all three of them, decreased T, B, and NK cell. RAG2 would result in decrease in T and B cell, but normal NK cell, RAG1 mutation, my bad. And JAK3, similar to interleukin 2, decrease in T, normal B, decrease in NK cell. Now this thing is important to differentiate between which genetic involvement, which genetic defect is present, right? So from the given information, our answer would be ADA deficiency, right? We won't go with the most common answer, because the most common gene involved is our interleukin 2 receptor involvement, right? Which is an X-linked recessive, which is inherited in an X-linked recessive fashion, right? ADA deficiency is the second most common and is autosomal recessive. Okay. We won't be marking it as option A because interleukin 2 receptor gene is most common, right? We would be marking on the basis of the subsets that are involved. If the subsets are not given in the question, then we would mark it as interleukin 2 receptor mutation, because that is the most common one. Okay. So SCID is quite an important topic from our examination point of view. That's why we are discussing it in a bit more details. Let's have a look into the next question. Features of SCID include commonly associated with diaper rash. That's a true statement. Two important things that we need to remember. One is diaper rash and another is candidal oral thrush. Candidal oral thrush. These two things are associated with SCID, very much specific to SCID. Decreased production of interleukin 4, 7 and 15. That's also a true statement. Remember that decreased interleukin 4 is associated with inhibition or defective class switch that would result in decreased immunoglobulin, that is B cell defect. Then decreased interleukin 7 would result in decreased T cell function, and decreased interleukin 15 would result in decreased NK cell function, Okay. Small or absent thymus on imaging, that is also a true statement, because SCID is a combined immunodeficiency where both your B and T cell lineage will be involved. We might even get an absent thymus on imaging over here. And correctable by bone marrow transplant, that's also a true statement, because hematopoietic stem cell transplantation over here is curative. So all of them are correct. Our answer should be D, A, B, C and D. Okay. Moving on to the next question. A 5-year-old patient presents with recurrent Staph aureus abscess, lymphadenitis and pneumonia. Nitro blue tetrazolium test is negative. Which of the following statement is correct with respect to the diagnosis? Now this nitro blue tetrazolium test is a marker or measure of the phagocyte oxidase activity. If the test is positive, it indicates a normal phagocyte oxidase activity. But if it is negative, this suggests of chronic granulomatous disease. Over here the test is negative, right? So our diagnosis would be chronic granulomatous disease. Now in chronic granulomatous disease, there is defective NADPH oxidase system of the neutrophils, right, of the macrophages and the neutrophils, right? That would result in inhibition of the oxidative burst. That would result in increased risk of catalase positive organisms, and the most common catalase positive organism that is involved is Staph aureus, right? That's why the question mentions about recurrent Staph aureus abscess, lymphadenitis and pneumonia. Let's have a look into the options. Which of the following is correct? X-linked recessive form is the most common form. Yes, that's a true statement. Remember that CGD can present as both X-linked recessive and autosomal recessive, where X-linked recessive is more common. Okay. Catalase positive organisms cause infection. That's a true statement. Dihydrorhodamine test is diagnostic. That's a true statement. It is a flow cytometry test. It's a flow cytometry based test and is better than nitro blue tetrazolium test. Okay. And interferon gamma therapy is beneficial. That's also a true statement. It is beneficial, but remember that it is not curative. It is not curative, but beneficial. So answer would be D, all of them. Okay. Moving on to the next question. Now 7-year-old has severe periodontitis, omphalitis and delayed separation of umbilical cord. The neutrophil count is found to be high. Now whenever we get the triad of recurrent infection, we have high neutrophil count and delayed umbilical cord separation. This triad will suggest a diagnosis of LAD1, right? LAD1, leukocyte adhesion deficiency type 1, and is due to deficient CD18, which is an integrin. Now, how to differentiate it from leukocyte adhesion deficiency type 2, right? Because it also presents with recurrent infection. But remember that there would be no delayed cord separation. Delayed cord separation is very much specific to LAD type 1, leukocyte adhesion defect type 1. And certain important things in LAD type 2. This LAD type 2 is also associated with number 1, Bombay blood group. Why? Because LAD type 2 is due to fucosyl transferase mutation is due to fucosyl transferase mutation. Okay. And second, it is also associated with short stature and mental retardation. Okay. Shediac-Higashi syndrome. If we talk about Shediac-Higashi syndrome, the Shediac-Higashi, so B cannot be an answer. Shediac-Higashi syndrome is due to List gene mutation, LYST gene mutation. Now, this List gene mutation would result in a defective phagosome-lysosome fusion. Phagosome-lysosome fusion. This would result in a defective phagosome-lysosome fusion, and this results in accumulation or presence of giant granules in neutrophils. Giant granules in our polymorphonuclear neutrophils, right? And ineffective clearance of the bacteria. Remember the fact that Shediac-Higashi syndrome is also associated with oculocutaneous albinism and neuropathy, right? So this cannot be our answer. And myeloperoxidase deficiency, again, this is a phagocyte involvement, not a leukocyte involvement, and we do not get any of those features in myeloperoxidase deficiency. Okay. Moving on to the next question. Complement defects can cause SLE-like disease. That's a true statement, because C1, C2 and C4 defect can cause SLE-like disease. Okay. Angioedema, yes. C1 esterase inhibitor deficiency can cause hereditary angioedema, right? And this is mediated by bradykinin. So that's also a correct statement. Angioedema is also seen. Recurrent pyogenic infection, yes, this is also seen because of C3 deficiency. In C3 deficiency, C3 is an opsonin, right? So there would be decreased opsonization. And opsonization is a very important step to prevent pyogenic infection. That's why we can get recurrent pyogenic infections. And recurrent Neisseria, yes, recurrent Neisseria infection is due to C5 to C9 membrane attack complex involvement, right? There would be increased risk of Neisseria infection. So all of them are correct, right? So answer would be D. Okay. Moving on to the next question. Now, a 6-month-old male infant is brought to the pediatric clinic with a history of multiple episodes of otitis media over past 4 months. His mother reports that the child bruises easily and had persistent eczematous rashes over the trunk and flexural areas. Which of the following statement is false with respect to the diagnosis? Now, again, whenever we get the triad of recurrent infection, eczema, and thrombocytopenia, the first thing, or rather the only thing that should come to our mind is Wiskott-Aldrich syndrome. Okay. Now, what are the things? Now, certain important Wiskott-Aldrich syndrome. Which of the following is false? X-linked recessive disorder. Yes, Wiskott-Aldrich is an X-linked recessive disorder where we get a mutation of the WASP gene, where we get involvement of the WASP gene. Associated with T-cell deficiency, that's also a true statement. Associated with decreased IgM, increased IgG, and normal IgA, that's a false statement. Because in Wiskott-Aldrich syndrome, we get decreased IgM, we get increased IgA and IgE, and normal IgG. How to remember? Remember M, the arrow of M points downwards, so there would be decreased IgM. And A, the arrow of A points upwards, so there would be increased IgA. And E also increases because A and E are vowels, and we all know that vowels stick together, right? So answer, and males are affected more than females. Yes, that's also a true statement. It's an X-linked recessive disorder. Okay. So answer over here would be C. Okay. So with this, we come to the end of our discussion on immunodeficiency syndromes. Right. If you like this video, consider subscribing to my channel. And thank you for watching.